Good morning. Thank you for joining us for building a clinical informatics learning community. This is going to be session 4, evaluating usability and human-centered design for happy users and better performance. My name is Elizabeth Breidenbach. I'm a meeting event specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to present this event with my division colleagues. Before we get started, I would like to review a few housekeeping announcements. You have joined this online event by either physically calling in or using computer audio. All attendee lines have been muted and will be muted for the duration of this event. The duration of this live event is approximately 45 minutes, including introductions, presentations, and Q&A. Again, the duration of this live event is approximately 45 minutes. The chat box is open for the duration of this event, located in the lower right-hand side of your computer screen. You may have to click to expand it, but you can use this at any time. Simply type your comments, questions, or concerns into this box at any time, ensuring that you select the to everyone or to the all panelists section so we receive your comments, questions, or concerns. If for some odd reason we cannot answer your questions in the time allotted, we will make an attempt after the event has been completed. Friendly reminders that today's event is being recorded. All attendee lines have been muted and will be muted for the duration of this event. If we cannot answer your questions in the time allotted, we will make an attempt after the webinar is complete. At this moment, I'm going to turn things over to Julia, who's going to be introducing today's presenters. Julia, the floor is yours.
Thanks so much, Liz. I'm Julia Skapik, the Medical Director of Informatics at NAC, and thank you for joining us for this, the last of 4 in this series. We're very excited to talk about usability and human-centered design today. As some of you know, NAC has developed a human-centered design framework. We've been working into the design and development of a number of our health IT related projects. We're also working on some curriculum materials for both usability and human-centered design, and would love to hear from all of you in the audience as to what your needs are, how we can meet them, and what you'd like to see in terms of programming in the future. I'll go ahead and start by introducing Raymond Uy, who's our physician informaticist, and he's going to tell us about human-centered design today. Thanks, Ray.
Thanks, Julia. And on the next couple of slides, we're going to begin. And we're going to set the stage for our guest speakers, Dr. Henry Amder and Kathleen Figoni. And, when you're talking about human-centered design and usability in health information technology, a lot of people believe that what we're seeing in the clinics, what we're seeing in the field, and there's a lot of hype in artificial intelligence and all of these new technologies in healthcare. And a lot of folks think that that's kind of the end, that that's an all-in-one solution that's going to fix all of the problems. But what the reality is that these technologies are enablers or are just really tools to make our workflows better. And surprisingly, you will notice that there are a lot of informatics projects that are designed not because of not from the point of view of the end users, such as the patients or the clinicians or the people who are using the software, but a lot of these projects are focused on, for example, billing. For example, a lot of folks think or see that the HRs were built primarily by engineers who thought, hey, we should make sure the billing aspect is there, and maybe as an afterthought, we'll fix usability and we'll fix the end user experience. But what we want to do and what we're focusing on today, which is human-centered design and usability, would be to try to get us to reorient the way we think about our workflows, the data workflows and the processes, and how these technologies can help improve data capture and use of technology and use of the data, and to make you, the end users, be happier with what you're doing on your everyday basis when you're interacting with your technologies. So here we have the NAC human-centered design framework. We start from clockwise, starting on the top left would be, again, defining what your project's all about, defining your goals, scopes, and outcomes. This is pretty basic, but what's important in this framework would be 2A, starting at 2A and 2B on the top right-hand side, would be how do you tell the story? There are 2 ways. Again, one is to define your use case, which is the scenario, or what's the situation you're trying to solve. For example, in the clinics, you have so many people who want to get your vaccine, for example. So that can be your use case. 2B, the next step would be to define your personas, personas would be, for example, the clinicians, your MAs, your PAs, your nurses, and your patients, and what are their stories and why are they there, and what are their experiences. On the bottom would be number three would be defining your dictionary. When I say dictionary, these are your variables. These are the things you want to measure, for example. How do you define it? You put it in a dictionary or what's called a data dictionary so that we can capture or we can operationally define what we want to see. And then after collecting all of those, this will give you all of the materials necessary to come up with a strategy or a solution. And the whole thing of human-centered design really applies a lot within organizations who are trying to make their workflows for using EHRs even better. Starting from the bottom is trying to again, this is about defining the project and looking for evidence for usability assessment, for example, would be again another use case. And then 2A and 2B, you will see on the right-hand side, would be to interview users to determine usability issues and including usability metrics for the project would be similar to defining the data dictionary that you will be using and what questionnaires or what forms or tools are we going to be using to define usability in your EHRs or not just EHRs or in other technologies that you're experiencing in your community health centers. Again, this is basically the foundation. Again, you see what you're trying to achieve, define the situation, set your use cases, have a list of personas, and this is usually done live or in person, where you talk to the personas, and each persona would be putting their roles on a wall. But again, this can be all virtual, and this can all be done in different ways too. And last but not the least is collecting data. How are we measuring or how are we measuring this important data that we have defined in our use cases and to come up again with a good strategy in the end. Um, and defining your goals is again very, very crucial. A lot of people who begin to do this to apply HCD or to do usability studies, sometimes they're kind of lost. They do want to achieve something, but they don't know which elements are needed to achieve that goal. So in the middle, you will see that you should consider again the humans in the process or all of these end users who are greatly impacted by all of these things that you're trying to solve. And then again, defining your desired outcomes. This is an example of a use case. This is from Gravity or the Gravity Project, which is a project that focuses on consensus-based standards, establishing consensus-based standards for social determinants of health. And in this use case, you can see that this is the situation of Rebecca, who's trying to schedule an appointment with his with her primary care physician. So you define that you're telling a story of what's happening currently in the field or what you're experiencing. Then you move on to what's called personas. So in this case, the persona here would be from the patient's perspective. You can see the chief complaint is there, the history is there. So what is the patient experiencing, or what are the situations or personas, or what is the situation of your patients that your field persons are seeing? Next would be, don't forget, the personas would be your care team members. Like in this case, the persona here would be Mary Michaels. Again, this is all fictional, who is a medical assistant, and this has a narrative, and you have quotes on what she or he possibly is experiencing in the field. And workflow is tough and data flow is tough. So that's why defining roles and responsibilities and defining outcomes is very important. This is just an image that illustrates how complex things are from collecting health data and retaining data and using that data and mobilizing that data and looping it all back. It's very, very complex. And that's why defining, again, use cases and personas are very important, and it's part and parcel with human-centered design. Again, building a data dictionary, again, defining those variables, defining what you want to measure, and making sure they are measurable so that you can say at the end that, hey, we've improved speeds and our users are happier, end users are happy, our personas are having a better time. Defining, and mapping our data is also very tricky. You need to work with folks who are knowledgeable about how data flows within your system. So again, that's another persona in itself. And this is also part of what's called the quadruple aim, which is aiming for a better clinician experience. We know that in this past year during this pandemic, a lot of clinicians or nurses, MAs, physicians are really overburdened with taking care of all of these influx of and huge amounts of patients. Um, and using human-centered design and usability tools will be able to, again, improve and hit that quadruple aim of fewer alerts, automated documentation, and all of that stuff that in our heads we might not be experiencing right now, but in the future, if you work on it, you will be able to achieve it. And last but not the least, building what's called an implementation plan based on all the data that you got, based on the personas and use cases that you got, and putting all down and writing all down together with your team members. And again, connecting back human-centered design to technologies. Personas are used to set user requirements, which then can be used to do electronic test cases. Use cases, again, the scenarios would show or it will help illustrate the workflows, data workflows, and processes on your health centers. And then this would be used to create logic for automation. Last but not the least, again, the data dictionary will be used to define how the data and the data flows and how we can easily extract data that we need for research purposes, for other things and for other use cases that you need. And right now, I'm turning it over to our first guest speaker, Kathleen Figoni from the Center for Care Innovations. I would let her introduce herself. Thank you, Kathleen, for joining us.
Great, thank you so much. Let me share my screen. So hi, everyone. My name is Kathleen Figoni. I'm a program manager here at the Center for Care Innovation, as you just kind of heard. Let me share my screen. My apologies. Let's get this up and running. Okay, so as Ray mentioned, I have the pleasure of working at the Center for Care Innovations, and I work actually predominantly in our innovation and technology portfolio. And I'm actually currently leading our award-winning program, which is a Catalyst program, and it's really a skill-building program that helps with human-centered design. And I'll speak to some of that in the coming slides. I also lead some other programs that are kind of focused on care delivery transformation, but I won't go into those today. I'll save that actually for another day. But just to give you some context, some just additional context, because I'm going to be sharing a little bit of a use case from the field. Later in the coming slides. I actually, before joining the Center for Care Innovations, for just a little over 6 years, I worked at a federally qualified health center in Northern California. And I oversaw the innovation portfolio there, and I used design, systems thinking, methodologies in tandem with quality improvement, process improvement. And so today I'll kind of share a little bit around how that blended approach actually looked in the field. But enough about me. Let me kind of jump in and just give you a little bit of context around CCI and our Catalyst program. So just really quickly about CCI, we are a nonprofit organization based in Oakland, California, and our mission really is to strengthen the health and well-being of historically underinvested communities. And we do this by supporting the healthcare safety net across the United States, really. So we support FQHCs, public hospitals, social service nonprofits, so many different organizations. And how we do this is we create learning programs for these types of organizations. And we do it in 3 ways. We like to say we spark, seed, and spread our participants' work. And one of the programs that I'll be sharing today, as mentioned, is our Catalyst program, which is our human-centered design program. Let me jump straight into that. So just really quickly, our Catalyst program really is our human-centered design skill building program. And this program is designed to cultivate a community of innovators who learn and practice human-centered design. And as a catalyst, you're really going to learn how to work differently and apply these human-centered design techniques and mindsets to a strategic challenge your organization is facing. So it's a 20-week program. We take you from the very beginning stages to at the very end. You're going to pitch your solution to your team sponsor at the end. Just to give you some stats around this particular program, we actually launched this in 2013. Since our launch, we've trained 295 catalysts touching 82 different organizations across 5 states. And I think for me, one of the most profound stats, is our coaching stats. So 21 of our past catalysts have now become coaches. And actually being a former Catalyst participant myself, I can say it's great to have a coach, but it's even better to have a coach that has gone through the program, but also has similar experience working with similar populations, right? So they really kind of get who you're serving and what you're trying to do and how these methodologies actually work in your environment. But while these stats are awesome, I do think, however, the most important or valuable or biggest value add, I should say, is that this program really brings cultural and social impact, not just to your clients, but to your teams. And that objective has really constantly, remained consistent throughout the program's conception. Really, we really bring equity-centered design and surface that within this particular program. So it's more than a skill building program. We really center equity at the forefront of this work. Next slide. So just to give you some context about the program benefits. So this program really helps organizations take a step back. And one of the things that we teach first is that to truly understand the depth and complexity of the problem that you're trying to solve for, you first need to go to those that experience the problem itself and listen to how they're interacting with it, right? So in doing so, this really helps ensure our teams are working on the right problem. And I can't tell you how many times, when I was in clinic, we would come up with these like amazing, solutions. And then after we would implement them, we would find ourselves asking like, why aren't our numbers increasing? Why aren't we meeting goal, right? And I kid you not, every single time I went out to our staff and our patients in the community and I asked them what was going on, and I used some of these human-centered design techniques, really it surfaced that we weren't focusing on the right problem, right? So really this blended approach with human-centered design, quality improvement, really kind of solidified in my mind the importance of doing both. And just to kind of give you just some context around the types of systemic change that we see our participants kind of, working on solutions with, we've seen everything our catalysts apply these skills and mindsets to everything from technology to organizational culture to process improvement. And I would like to share with you a field example. When I was at West County Health Center, so that FQHC I had mentioned a little bit earlier, I did think it was important to kind of share that blended approach and what this actually looked like. So when I was at, my FQHC, one day my CMO came to me and said, Kathleen, whenever sites, they're not meeting their cervical cancer screening goal, and, they're running these PDSAs and they're not meeting it. And this care team is really good. They're always kind of meeting their goals. Like, what can you help them? What's going on? Can you just figure out what's going on? And so the first thing that I did was I looked at their data. I looked at their PDSAs that they were running, like, everything that they've been tracking over time. And then I took a human-centered design approach, and I took a step back and I interviewed staff. I interviewed patients, and I actually went out and I interviewed a couple of the community members. And really what I was looking for was, do they actually understand what cervical cancer screening means? Do they know what a PAP means? And asking really kind of open-ended questions that way. And for me, you know, human-centered design, just to give you some context, human-centered design is really the story between the numbers. I feel like you can't do one without the other, right? Your data is so much, you know, tells you a story, but let's like dig a little bit deeper and understand that story just a little bit more by hearing from our, you know, those that actually interact with the problem, if you will, itself. So I went out and I learned a little bit more around what was actually going on, what was rooted in the problem, if you will, and lo and behold, what, you know, the PDSAs that they were actually running had nothing to do with what the patients and staff actually identified were the root problem, right? So so what the problem and the themes were that were kind of presenting itself was actually, you know, our patients had no idea actually what a PAP was, what cervical cancer screening meant. They are also really concerned around like their insurance, like would their insurance actually cover, you know, a type of, you know, screening like this, right? So after having these themes, I presented this to the care team that was actually running those PDSAs, and together we created an aim statement. Just very simple based on kind of what we were hearing, and we knew that we wanted to get our cervical cancer screening rates up from 59 to 65%, and we wanted to do this by a specific date and time. And after we drafted that aim statement, we actually took an opportunity to create a how might we statement. And for those that aren't familiar with what a how might we statement is in human-centered design world, really it's an open-ended question that puts you on the path towards brainstorming those innovative solutions. So you can see here how we just you know, adapted our aim statement so that it was an open-ended question. And from there, once we did this with this particular care team, the care team actually invited, you know, some additional care team members to join what they called a co-design session. And they also invited some patients too that we had interviewed to kind of like understand the problem a little bit more. And we invited them because we really wanted to brainstorm with them solutions with them. And one way that we did that was through a human-centered design technique called concept sheets. And you can kind of see this on the very first bubble on the left-hand side. And really, when we were brainstorming, what this looks like was, you know, it's 5 minutes. You put the how might we question up on the board, you play some music, and you say, okay, let's get all of those wild and crazy ideas out. And I think they came up with like I think there was about 12 people in the room, and we came up with almost 100 ideas within 5 minutes. They were just wild and crazy ideas, but there were amazing ideas. And once we were done with that particular brainstorming, what we did all together with the same group, patients included, was we clustered those change ideas, right? So those solutions that we came up with that they drew were essentially our change ideas. And so we clustered them and we created a driver diagram together based on those ideas that they just had come up with, right? And once we were done with that co-design session, I had a meeting with that, you know, that care team that was running those PDSAs that I've been doing all of this work with thus far. And what we did was we started to prioritize what change ideas we wanted to kind of pursue for testing, right? And running those future PDSAs. And what we did was we took a human-centered design technique called the 2x2 matrix, which is the third bubble. And you can see we took all of those change ideas or the concept sheets, if you will, and we put them on this 2x2 matrix and we kind of mapped it out. And we said, okay, what is feasible based on what they, you know, kind of had designed or you know, brainstorm essentially. And we came up with 3 different ideas that they wanted to prototype. And from there, the care team took about an hour with and invited those same co-designers back. So those same patients and those additional staff members. And they prototyped with them 3 different solutions. So what that means was they took those ideas that were on that paper and brought them to life. They used cardboard, they used glitter, they used all of this stuff. And it was really, really fun. It got our care teams and patients jazzed up and excited about doing this work, right? It's one thing that I love about human-centered design. It gives you that extra little, it's just fun, right? It's fun. So after they prototyped these solutions, what they did was they took some time with patients and those additional care teams, and they actually crafted the PDSAs. So they took that same form that they were using before and that they weren't actually meeting goal with, and they took the prototypes and they said, okay, let's plan our PDSAs. How can we actually, move the needle up on this, right? Like, how are we actually going to bring this to life? And so as we started running these PDSAs, we saw them, you can see on the right-hand side, we saw our numbers actually increasing, right? So all of this to say is, if we didn't take the time actually to listen to our staff, our patients, and really kind of bring in the voice of the community, and design solutions with them, we probably would have continued to miss goal. Again, I think it's incredibly important to, have your data, inform us, but also let's go to our participants and our staff and our patients and say, because they're deeply rooted and understand the problem, let's go to them and ask them what is actually going on. It's the narrative between those numbers that really kind of bring this to life. Again, human-centered design is just, understanding the depth and complexity of the problem that you're really trying to solve for. Sometimes I think we forget to do that. But all of that said, this is just one use case, but I encourage you to go to, the Center for Care Innovations.org and, just check out all of the other amazing kind of use cases that we have around human-centered design, or always feel free to email me, Kathleen at careinnovations.org, and I would love to kind of share just a little bit more around human-centered design and case studies with you all. So thank you so much, and I will hand it back to you, Ray.
Thank you so much, Kathleen Figoni, for that great presentation on applications of human-centered design. And you guys saw that using the data that they got and using the metrics and the PDSA, they were able to demonstrate quantitatively that there was improvement because they used these processes. On our next and last but not least, our final speaker would be Dr. Henry Amder. He is an obstetrician and gynecologist from the New London, Connecticut area. He is affiliated with multiple hospitals in the area, including Westerly Hospital and Lawrence and Memorial Hospital, and which has served the community health centers and the community health center catchment and population in the area. He received his medical degree from the Universidad Autónoma de Guadalajara and has been in his OBGYN practice for 20 years and has been supporting human-centered design and usability in his organizations. Dr. Amder, the floor is yours.
Hi, I'm Henry Amder. I practice obstetrics and gynecology in the New London area for 35 years, both in private practice and in clinic. I had multiple administrative roles, including department chairman, medical staff president, and hospital board member. Additionally, I wrote and implemented my own office management software and implemented the first EMR in our hospital, along with the many others that followed. I'm going to present human-centered design from the provider point of view. The physician part of me apologizes in advance for any usability issues that I may have in this web. Here's the first one.
Yes, so I think the space bar's not working, Dr. Amder, so let's just use the arrows on the left. Yes. Oh, Dr. Amder, you're muted. Just one more thing. Yep. Oh, Dr. Amder, you are muted. Thank you.
Am I on
Yes,
mute
sir.
now, Raymond?
All good. Thank you, sir.
We're good? Good? All right. Every patient visit is supported by the three legs of a stool. Clinicians provide the medical input for the visit. Administrators provide the workplace, human resources, scheduling and billing. Information technologists support the software, network, security, and cybersecurity required for modern medical practices. Historically, private practice clinicians filled the roles of providers, administratively ran the practice and shop floor, and implemented electronic medical records for their practice. Having a hands-on responsibility for all these services gave them a better appreciation of the necessity, complexity, and interdependence of this triad. Today's contemporary practitioners are more frequently employed. They have less understanding of administrative responsibilities, billing, and information services. To provide information and data management, order entry management, result management, clinical decision support, electronic communication and coordination, patient support, reporting, and population health management, and administrative processes. What is EHR usability? While providing all of those above, it's supposed to be useful, usable, which means learnable, intuitive to use, efficient in keystrokes, screens, and mental steps to complete the task, error tolerant, in other words, easy for a user to recover from an error, and the system is supposed to be likable. The hoped for outcome with the implementation of an EHR system was improved clinical efficiency, improved provider satisfaction, improved patient safety, realized cost savings through improved efficiency and revenue collection, and improved evaluation and management compliance, along with improved collection of meaningful use data. According to Steed and Lin, no electronic health record to date has effectively supported clinical work design and thought process. EHR may actually worsen healthcare if future systems do not have better usability to support the way clinicians think, do work, and make decisions. EHR implementation has decreased productivity from 4 visits per hour to 3, and EHR has resulted in increased provider work hours and therefore increased costs. EHR use could actually increase errors, decrease patient safety due to a need for user workarounds like post-charting and bypassing built-in data checks. So the usability of electronic health record is critical in delivering the hoped for improvements in productivity, efficiency, and patient safety. And awareness of the usability problem typically follows a wake-up call. And that is recognition of significant decrease in productivity following the implementation of new software, or more problematically, following a critical safety event, a poor clinical outcome linked to usability-related clinical mistakes. These events motivate the deployment of more resources to improve usability. The usability maturity model is a tool to evaluate where in an organization is in the recognition and the implementation of usability. Unrecognized is lack of awareness of usability, no practices, policies, resources allocated. And this is where most organizations are in this country today. Providers, administrators, and IT working in silos. The next stage is preliminary, where there's sporadic inclusion of usability, extremely limited resources expended, implemented, where you recognize the value of usability. There's small teams doing usability work, integrated, all benchmarks of usability are implemented, and strategic, business benefit is well understood, usability is mandated, money and people are part of each year's budget, the results of the are used strategically throughout the system, and at this level, all the silos are gone and all the legs of the stool are interconnected. The ideal world healthcare visit, the provider and the patient have a face-to-face encounter. Anything that interferes with the provider workflow or thought processes diminishes the benefit of the encounter to the patient. Reliable and meaningful history is dependent on human contact. Creating a rapport is impossible when the provider's back is to the patient entering data into a computer. A tablet-based data entry and/or thoughtful exam room design that allows for face-to-face conversation during the visit provides more reliable and useful data. It's not just the EHR, but the environment in which it is deployed that enhances the value of the patient care encounter. Providers are taught to approach a clinical visit in the SOAP format: subjective, objective, analysis, and plan. While subjective and objective data entry are amenable to specific data point collection, analysis isn't really. It's not amenable because there are too many variables. Allowing free-form charting by typing or dictation should be encouraged. The plan requires a mixture of free-form entry, which is then supported by CPOE and real-time electronic communication and coordination. Chart input forms that follow this format will help keep the provider's thought processes organized and help efficiency. Formatting must be standardized. Too much configurability, which many of these EMRs have, leads to confusion and errors. Changes in data entry chart formats and workflow shifts the provider's attention from the patient to the EMR. Placement of critical demographic data must be consistent throughout the EMR to minimize charting on the wrong chart. Non-standardized input formatting creates tremendous provider frustration and fatigue when faced with having to figure out where to put the data. Providers want to focus on data collection, not where to put the information in the chart. Use specialty society forms whenever available. For an example of this is OBGYN Dorsetta for women's health providers. This software is formatted in a familiar and intuitive way for obstetricians and gynecologists. Built-in reminders for critical lab and imaging studies reduce risk to patients. Specialty organization guidelines and reminders are built into the software and consistently updated. Built-in guidelines reduce the likelihood of medical legal errors. Don't reinvent the wheel. Use existing design models to create forms for other clinical areas. Electronic medical record output is another source of provider frustration. Medical record output is frequently and poorly displayed. Providers get frustrated in waiting through pages and pages of chart output to find necessary information. Output typically includes all of the data input fields, not just the ones that are relevant, positive and negative. This leads to provider fatigue, frustration, and the possibility of missing critical information. So building standardized report outputs that focus more on concise data while maintaining availability for data for deep dive when necessary. There are several evaluation techniques for assessing the usability of an electronic health record. These include heuristic evaluation, cognitive walkthroughs, laboratory testing, remote evaluation, and usability questionnaires. The conclusion by EHR Usability Toolkit article was commonly used usability evaluation techniques such as heuristic evaluations and more rigorous methods such as laboratory testing are practical for primary care settings. The usability questionnaire would provide the best option in the toolkit for evaluating EHR in a primary care setting. The usability toolkit evaluated multiple pre-existing questionnaire candidates to evaluate electronic health record systems. No existing questionnaires could adequately assess the usability problems specific to an EHR in a primary care setting. So here's a real opportunity for us to create that questionnaire. So the recommendation in creating this questionnaire was to have it consist in 3 parts: analysis, education, and tailoring. The analysis component would consist of questions set addressing usability issues in the appropriate clinical context. The education component would provide information on usability issues and why it is important for the clinicians to identify and understand these issues. And the tailoring component would provide a summary that clinicians can share with vendors and EHR certifying bodies to complement their user-centered design program. So in conclusion, providers, administrators, and information technologists need to recognize and value each other's role in the delivery of safe and efficient healthcare to patients. The 3 groups need to work as a single team to create software and workflows that maintain providers' typical mind flow while collecting the necessary data required for billing, compliance, and meaningful use. Linking together the 3 legs of this stool will create a safer, stronger, and more stable platform for providing service to the community. That's what I got.
Thanks so much, Dr. Henry Amder, for showing us some very interesting and very important aspects of assessment of usability in the HRs and what a lot of our providers are experiencing right now. And when you think about it, everyone, we have all these pop-up clinics, vaccination clinics for COVID vaccines, and we don't know which software they're using. Are these software integrated? Are people having a good time using this software? Or again, the question always is posed using electronic or HIT tools. Is it easier to go back and use paper and pen? And we see still that a lot of organizations out there are still using those because it works for them, the workflow is there. But for those that are forced to or are integrating all of these new HIT tools that are for some unwieldy, or people who are not really familiar or not very technologically savvy with doing stuff in the computer may really affect their workflow. Now, not everyone can type fast. Some people type slow. Some people have a difficult time navigating. So these are some open source questionnaires that people are able to use. On the next slide, I believe would be if I could get the control over the slide. There you go. These are sections from the QUIS user interface satisfaction. You'll see that part 1 to part 3, there's system experience, overall user actions, and screen. Are the stuff on the screen usable? Are the layouts helpful? And these are on like a Likert scale. I think on the next slide would be another example of part of a QUIS survey, and that's pretty much it. There are open source tools out there that everyone can use in your organizations, and we're opening this to the Q&A portion. And I guess while everyone's thinking of what a question to add to, are there any questions in the chat? If there are not, I would pose a question for either Kathleen or Henry. Go ahead, sorry.
No, I'm just reviewing the chat right now. I just want to give everybody an opportunity if you've missed housekeeping. The chat box is located in the lower right-hand side of your computer screen. This is your opportunity now, while we still have our presenters, to type in your questions into this box. So Ray, feel free to pose your question out to them, and I'll check the chat box.
Yes, thanks so much, Liz. I think one of the first questions that would come to mind when looking at human-centered design and HCD is none of us are experts. We don't know. We've never tried HCD. We've never done usability. What is the first thing we should do? Should people hire? Should people talk? People meet? What would be the first thing a person should, an organization or a person who is interested in doing this in their community health center should do? I think Kathleen, you can go first.
Yeah, great question, Ray. I think that there's no wrong way to do this, right? I think you don't need to hire someone to do it. You already do this really well anyways when you're with your patients, right? You are doing motivational interviewing, you are connecting with them. It's just asking just targeted questions, just an open-ended questions, which you already do about a specific experience. And then just kind of looking at the themes. And one thing that I say, you know, often questions that I get is how do I know when I'm done with interviewing, or that I know like like that this is a theme. You know when that theme keeps coming up over and over and over again. So it's called thematic saturation, right? So oftentimes I say the sweet spot is around 7 to 12 interviews is typically the sweet spot. But anyone can do it. You can have your call center do it. You can have your front office do it. You know, the providers are doing this already and they're amazing at it. So if someone is interested in and excited to work this way, tap into them. That would be my first recommendation.
Thanks, Kathleen. And Dr. Amder?
I think there's always computer geeks in a provider pool that are interested in this kind of work and understand workflows on the physician side of it, but then understand the back end too. So I would recruit from my own organization champions for human-centered design and work with them to improve the workflows and front-end design of the software.
Thank you very much, Dr. Amder and Kathleen, for those insights. Again, just to summarize those, again, we are working within in resource-limited settings. The first question, again, a lot of people would think is, where's the funding? We don't have money for this. We don't have people for that. And you heard from Kathleen and Dr. Amber that, hey, there are people within your organization who, you know, this is their lives. This is the work they do every day. This is a lived experience, and this is a lived and collective, personal and collective experience in our community. So again, just taking that first step is very crucial. And thank you again to our speakers, Kathleen Figoni and Dr. Henry Amder. Thank you for your time and your expertise. I'll hand it over to Liz.
Awesome. Thank you so much, Ray. We really want to thank everybody for taking part of this learning community. It was such a pleasure having you. Within the next 2 to 3 business days, you'll be receiving a survey. This lets us know how we did and how valuable this series was to you. With that being said, all of these recordings will be available on a playback on the NAC Clearinghouse. I hope everybody has a fantastic day. We'll talk to you soon. Thank you. Bye-bye, everyone.